Thank you very much. Thank you very much to the organisers for inviting me. It's a real pleasure to be back here. When I was invited to speak, I was asked to talk about a little bit how we got where we are, and that's what I'm going to do, and then see where we may go. Right. So what has been happening to cholangiocarcinoma? Well, as we heard from Shahid, we come from quite a low baseline, but we have increasingly, I think, brought pathology to add to this, and that's really what I'd like to convince you of. So under the microscope, there's not just the cholangio, but actually pathology itself. What is it that pathology should be doing? So this is the structure of my talk. I'm going to talk about a little bit what's happened in pathology. I want to talk about the pathology and clinicians. We heard a lot about MDTs, very interesting discussion. Pathologists involved with research, very important to a number of us. I think there are 3 pathologists in the room, and they're all involved in research. I think it's a 100% score rate here. And I want to say a little bit at the end about pathologists and patients, a topic not often discussed, it has to be said. Okay, so when it comes to pathology, there are a number of new entities that have been described. I guess IgG4 disease has kind of really, become totally accepted. This was something we were really unaware of. And here, pathology not only is important in making the diagnosis, but indeed, pathologists are important in identifying and defining the parameters for this condition. Besides the biopsy, I feel a bit after Chris's talk about how, all the hard work endoscopists do, and, these are challenging places to take tissue from, and the pathologists in the audience will agree with me. These can be very, very difficult biopsies, and I really think they have to be done by specialist pathologists, first of all. But when it comes to IgG4 disease, it's difficult to apply the established criteria to such small bits of tissue, and also increasingly the overlap of IgG4 disease with PSC and cholangiocarcinoma has to be borne in mind. So it's an important diagnosis, and we're always very, very happy when we make it. I'm not sure whether I'm allowed to talk about combined hepatocellular cholangiocarcinomas at this meeting, but it's something which has come very much into the fore for pathologists and for others. And you can see the differences between 2010 and 2019 World Health Organization classifications. There's been a bit of clearing up. The cholangiocellular type has been quite rightly kicked out and moved fully into cholangiocarcinoma. And now we have a much clearer idea what we mean by these entities. As a pathologist, of course, I'm going to show you some pictures. Here's a tumor, a single solitary tumor with 2 very different areas. You can see there in C and F, one looking rather liver-like and one looking much more glandular-like, and the top one stands for HEPAR1, which is the liver marker, the bottom for CK7, which is in this context a cholangio marker. This is a very classic type cholangio. We're diagnosing these more and more because, as the old pathologist saying is, you only see what you look for, you only recognize what you know. And now we're all thinking about it, we're diagnosing this more often. There's another kind, a rather more challenging type with intermediate type cells, where the tumor has each cell has the properties of both cholangio and liver cell cancer, and these are a little more difficult to diagnose, but again, I think pathologists have a very critical role in this. We leave it to our clinical colleagues to understand what the therapeutic implications are. We've heard already a reference to small duct and large duct cholangiocarcinoma. I'm mentioning it here for 2 reasons. First of all, this is very simple pathology. I mean, looking at those 2 slides, you can see one has small glands and one has big glands. Any of us could have made this distinction, but it took us a while for the penny to drop. And has also been alluded to, the tube sites are associated with quite distinct or gene alterations. So this is something which is, I think, shows how simple pathology can contribute very significantly to understanding. Obviously, it needs further work afterwards, but it shows what pathology, in its simplest forms, can contribute. So much more to say about the pathology. I'm just stuck in a couple of reviews there. Okay, new classifications. Well, it's perhaps, I know, I'm going to say the curse of our age, that everyone has to come up with a new classification all the time. I mean, this is 2 of my favorite papers. The top one, a novel approach to biliary tract pathology based on similarities to pancreatic counterparts. Is the biliary tree an incomplete pancreas? I think it's a brilliant title. I like it so much I put it in red. I think this is a very confusing area. It is certainly for pathologists, and I suspect for radiologists and clinicians as well. The nomenclature of these tumors at these precursor lesions for cholangiocarcinoma is complicated and not always very consistent, and new subtypes are continually being described, but this is a very important area for pathology to contribute to. Oh, sorry. Then, of course, the TNM. Sometimes when you see the changes, you kind of wonder, is this really worthwhile? Again, the 7th and 8th editions being compared. See, T1 is now being split into tumors more than 5 and less than 5. Now, maybe that's very important to whether they're suitable for transplantation. I was hearing how important the size is, but that's something separate. Whether you need them as 2 different categories, I don't know. So T1 was split, and T2 was consolidated. Who knows which way around it will go the next time round. So some of these changes are really, in my opinion, have a poor evidence base, but we do with what we have. On the other hand, if we look here for gallbladder cancer, look at the distinction T2A and T2B, which is based on which side of the gallbladder. One side faces into the liver, one side faces out. Does it matter which side is affected? Well, it does matter in terms of prognosis. So here again, very simple pathology. It might be a registrar doing the cut-up. They really need to record properly which side was involved if we're going to give our patients the best information we can about their prognosis. And again, this is pathology which costs pennies, but takes some attention to getting right. Neural invasion, well, we all know cholangios, it's one of the kind of identifying features of cholangio is neural invasion. But the whole relationship between nerves and cholangio is really undergoing, I think, a re-exploration. The trophic effect that nerves may play on the tumor microenvironment and on the tumor themselves is only beginning to be recognized. And I think this is something we, as pathologists, can contribute to. I quote a relatively recent paper. Mostly they looked at pancreas as well. It's not just a route by which tumors spread. Nerves have a dynamic relationship with this kind of cancer, and we need to be looking at this more. Now, an idea which has sort of been emerging is this carcinoma of unknown primary. Sorry, I should have written that out in full, and cholangiocarcinoma. So there was a paper earlier this year, which showed that based on radiological criteria, a third of patients who had a carcinoma of unknown primary fulfilled the radiological definition for intrahepatic cholangiocarcinoma. And then there are molecular studies suggesting the gene profiles of a significant percentage of carcinomas of unknown primary match those of cholangiocarcinoma. So, what does this mean? I think we need to look at this all over again. There was a seminar which I was involved with at the end of last month, April, where pathologists were getting together to say, what can we contribute? Maybe we have, we need to do better in distinguishing carcinomas unknown primary, which are very often adenocarcinomas, from true cholangios. And I think this is going to be a big growth area in what pathologists can contribute. I remember many of you were talking about the AVC trials earlier. I was involved very peripherally at one stage, and I was reviewing the pathology for the trials. And my job was simply to say it's an adenocarcinoma. I was never asked whether could this be cholangio or not, because that was all done on the radiology. We as pathologists recognize how dependent we are on our radiological colleagues, but that doesn't prevent us trying a little harder. New techniques. Somebody said I was going to talk about this. I'm glad I am. This is a recent review of the ancillary techniques that have been suggested. And it's a very good review. I strongly recommend it. If you look at that list there, if I can get the pointer to work, you notice that the specificity for most of these lesions, these tests, is very, very good. It's the sensitivity that's the problem. And I'll be interested in people's comments in different centers, but this really hasn't, in my opinion, been the solution to all our problems. In the difficult cases, it's difficult. And these special techniques, whether it's FISH or even next generation sequencing, do not solve all our problems. So this is, again, we have tried and we need to keep trying. I was kind of interested, and nobody's kind of talked about this yet. When I remember when HER2 testing came in for breast cancer, we all thought this was really state-of-the-art and very exciting. And now every cancer we look at, we are asked about HER2, MSI, and here is a recent review looking at the frequency of these changes. So I don't know what other people's practice is, but pretty much always now we get HER2 and MSI on all our cases. I know MSI particularly is very uncommon, and I'd be interested to know what other people's practice is in this area. But this is certainly an area where we need to contribute. But I don't think this is fully worked out. This may sound like a bit of Anoraki histopath stuff, but the scoring of HER2 in breast cancer and, say, in gastric cancer is different. I'm not sure anyone really knows how HER2 staining in biliary cancers should be interpreted. So again, simple things that we need to firm up on. Right, a topic which I'd be very happy to talk about for a long time. We all know that pathology is going digital, or is at some stage going digital everywhere. At the moment, the uptake in the UK is certainly rather patchy. But with digital pathology comes AI and deep learning. And I'm sure everyone's involved in projects relating to these kind of areas, amongst my other two pathological colleagues. This has a huge amount to offer us. There's so much more we can learn from these sections. I've just chosen one relatively recent paper showing that if you combine a pathologist with a deep learning algorithm, the pathologists are more accurate than if they do it on their own. It's not rocket science, but it makes us better at what we do, and we need to embrace it, and we need to continue to think how we might do it in other areas. Centralization and specialization is certainly something people have talked about. And, MDTs were introduced in 1995. That's even before Shahid completed his PhD and the AMMF was started. And this is just a quote about, it's the gold standard. Now, absolutely, and I hear all the reservations and all the issues raised today were very, very interesting to hear. Pathologists, of course, have a special are part of the core team, makes us feel really, that really we are clinicians in the end, despite what our friends and relatives may say about us. But I think it's really important because we as pathologists, I always say to my trainees, the difference between a good pathologist and a very good pathologist is a very good pathologist understands the clinical implications of what they are saying. We're not doing something in some back room somewhere. We have to know, when I say this, the clinicians are going to say, we can do this, we can't do that. That's really important. And that's where do we learn this? We learn this from the MDT. I just came across this little quote, which I draw to all your attention, that MDTs should be arranged around the working needs of radiology and pathology. Draw your own conclusions. Going on with the specialization of pathology, we talked about today, how many major units there are for this kind of work, and of course they're all supported, big centers, lots of pathologists. I just got these pictures, some figures from very kindly provided by Judy Wyatt from Leeds. This is the liver EQA scheme. This is the scheme that pathologists who sort of self-identify as people with a special interest in liver pathology are members of. And in 1994, there were 23, and I can tell you my membership number is 21. So I was there. This has gone up slowly and then has continued to accelerate up. So this is not the same as how many liver pathologists know a lot about hepatobiliary cancer, but this shows that specialization is coming in more and more, and we really have to address this. I can speak for ourselves at Imperial, and I'm sure it's the same elsewhere. The number of pathologists coming into these kinds of specialties is hard to recruit. It's hard to recruit. And if you want pathologists with an academic interest, it's harder again. This is just some work we did. Gallbladder cancer sent in to us for central MDT review. This is how they were staged. In black was by the referring centers, and in red, how we re-staged them. This is based on the slides that we were provided with, so we cannot know whether we were given enough blocks to look at or not. it's not that we're better pathologists than people who are doing lots of things. It's just that we just do one thing. In the same way as the surgeons who do one kind of surgery are going to be better than those who do a little bit of everything. And that's true for pathology as well. And I think that really has to be acknowledged. Finally, I want to talk about research now. When it comes to research and animal models, which is a topic very close to my heart, I think, again, pathologists play a critical role. This is just from a recent review, and there's another review there, I think, from the Edinburgh group. Different types of models for cholangiocarcinoma, but I think pathologists have a very big role in interpreting these. We wrote a paper a few years ago now looking at another liver disease, looking at animal models of fatty liver hepatitis, and we found that those papers which had pathologists as co-authors had higher impact factors than those which didn't have pathologists as co-authors. Again, I just throw that out there to my clinical and research colleagues, and you may draw your own conclusions. But I think animal models are very interesting, and I think a pathologist who is used to looking at these specimens clinically has something particular to add to looking at an animal model, rather than maybe a scientist who has plenty things to contribute, who doesn't know how this relates to what we see clinically. Human tissue for research, a lot of people have alluded to this already. We are very conscious of this. I don't need to, for this, this is a partnership really with us and patients who have to give the agreement for tissue to be made available for research, and it's really important we make the case and we make it in a strong and persuasive manner. So much depends on using tissue we have for research, so much for getting the most information. When I'm talking to just an audience of pathologists, I often say that we are given tissue by patients. It puts a huge onus on us to get the maximum information we can. We're not just trying to clear a tray of piles and piles of slides, although indeed we are sometimes just clearing piles and piles of slides. Each case, especially these difficult cases, we really have to give our minds to what can we do, both clinically and research-wise, to extract the maximum information. There you go, you can look around the audience. This is a very excellent talk Tim Kendall from Edinburgh gave when the Pathology Society, I think their weekly sort of grand round meetings, talking about the particularly challenges and opportunities for pathology to contribute to research. And I didn't embed the video because it would take too long to watch, but I strongly recommend watching it because I think it helps show where pathology is going. Finally, pathologist involvement with patients. People are always saying to pathologists, don't you miss the patient contact? And I have to be absolutely honest, most of the time dealing with my clinical, my physician and surgical colleagues, there's enough patient and human contact for me. But this is obviously an important point. And really, I have to say, I remember the very first meeting of these I came to, and I spoke, and a couple of families from patients came and talked to me. They wanted to understand. They had questions. And honestly, it made me think a little bit differently about what I do. I think it is very easy for pathologists to lose that immediacy of contact. And that goes back to what I was saying before, that sense of privilege of having a part of someone available to you to extract information from. For me, it's important, and it's something which hearing patients' families talk this morning and later really speaks to me, really does. I'm happy to say AMMF included pathology on your website very early on. I remember Shahid coming to me to ask to write something. My only comment to the committee is I think it probably needs a bit of updating now. So I think, no, feel free. But I think it's really important. And actually, we're lucky as pathologists, we were included very early on in this process. And we thank you for that, really we do. Okay, so I've talked to you a little bit about what's happened with pathology. I think we are organizationally more involved. I think in research, our contribution is continuing to increase, and our diagnostic role is not unimportant. So the microscope may have moved on, and like the pathologist in this picture, I'm glad I'm on the winning side. Thank you very much.